Hello, everyone, and welcome back to the Completed Life Lunch Hour series. My name is Sarah Kiskaden-Bechtel, and I'm the Program Director for the Completed Life Initiative. This Lunch Hour series is an open invitation to you, the Completed Life community, to join our foremost experts at the Completed Life Initiative in conversation on various topics within the scope of what it means to live a completed life. Today, we are very fortunate to be joined by Completed Life Advisory Board member Thaddeus M. Pope, who is a bioethics expert, patient rights advocate, and health law professor who has written extensively about the right to die, end-of-life decision-making, medical futility, and death. Moderating today's conversation, we are very fortunate to have our very own Delano Kopru, who is a member of our esteemed advisory board as well. And without further ado, I will turn it over to Delano to continue and begin the conversation. And please feel free at any time to send your questions in via text chat. I will be monitoring the text chat, so please don't hesitate to send your questions. So with that, over to Delano, and thank you so much.
Welcome everyone, and Thaddeus, we're
call from
Delano? Sorry about the technical issue. Would you like to go ahead?
yes, the mute button. In these times, we all know about this mute button. So, Thaddeus Pope is a foremost expert on medical law and clinical ethics. He directs and is a professor Health Law Institute in St. Paul, Minnesota. And really, without further ado, we're going to get right into it since this hour is short and there's a lot to cover. So our conversation today will deal with medical aid in dying, and particularly thinking about how various states have negotiated the blueprint for what are the procedures in place for medical aid in dying. For those of you who were on our call before we formally began, we got a bit of a glimpse into Thaddeus's life in terms of the ways in which innovation and conformity play a part in his own idea and approach to this, and in his observations across 11 states so far. So, Thaddeus, I think you have a slideshow you want to begin to open the conversation.
Yeah, so this will be short, right? This is just to provide a quick foundation. This is just a foundation, a very brief foundation, less than 10 minutes, and then we're going to move to your questions. Although if people have better questions, then we'll just move straight to their questions and skip your questions, Dylan. I think, right? But let me just do this brief background just to get everybody on the same stage. Let's see. Okay, hopefully you see that. Okay, good. So thanks for having me. During this call, this 60 or 90-minute call, right, 500 people are going to die in the United States just during this call. 2.8 million in the United States this year in 2021. And many of those people want to control the timing and the manner of their own death, right? Either because they lost the ability to enjoy activities that are meaningful to them, because they fear illness-related suffering, or they fear losing control and independence. And many people in every state already hasten their death every single day, right? Either people who have end-stage renal disease, many of them stop dialysis. People on mechanical ventilation withhold or withdraw that. People who have implantable cardiac devices deactivate those, and so on. This has been long accepted, both in law and in practice, right? We have advanced directives and living wills, and the whole idea there that we think that it's right that we should be able to judge for ourselves what quality of life is acceptable and what quality of life is not acceptable. In MAID, medical aid in dying is just one more option. So what's MAID? It's an end-of-life option that's available for a small number of patients adults 18 years and older, who have decisional capacity. So nobody can request MAID on behalf of somebody else. You have to be terminally ill, which means you have an incurable and irreversible disease that's expected to cause your death within 6 months. And you have to have been counseled on options and alternatives to MAID. If you are eligible, given those conditions, what do you get? You can ask and receive a prescription drug that you then may, you don't have to, you may self-administer to hasten your death. Traditionally, that's been Seconal. You'd open 90, 100 milligram tablets and mix that in a liquid. But more recently, it's been primarily a compounded drug called DDMP. Most patients take that by mouth, so they mix the drugs in apple juice or something like that and drink it. Although people with a feeding tube can press a plunger on a feeding tube and administer it that way, or press a plunger on a rectal tube and administer it that way. However it's administered, whether by mouth or otherwise, it's the patient alone, the patient herself, who takes the final overt act that causes the drugs to enter her body. It's worth noting that about a third of those who get MAID prescriptions don't ingest the prescription. So the green line here from Oregon are the number of prescriptions written. The purple line is the number of prescriptions taken. And you can see there's a gap between those two colored lines. And the point is that there are three different populations that benefit from having MAID as a legal option. There's those who actually used to take the drugs because they found their conditions to be intolerable. But then there's those who have the drugs but don't take them. They still benefit because they have peace of mind and are comforted by knowing that they have the drugs should their suffering become intolerable. And then there's those who haven't even obtained the drugs, who also are comforted and are given peace of mind by knowing that the option is available, even if they haven't yet availed themselves of it. So how do you get the prescription? Right, there are numerous safeguards. You have to make multiple requests and have multiple screenings by a prescribing physician and by a consulting physician, and then sometimes by a mental health physician as well. What they do is they confirm that you have capacity, that you're terminally ill, and that you understand your options. The key option that you really need to understand is the option of hospice care and of palliative care more broadly. Most patients who get MAID already are on hospice, but if a request is made for MAID, even if you're already on hospice, almost invariably the first thing that happens is there's a reevaluation and a reduction of efforts to address the unacceptable condition. So MAID is sort of a last resort option. There's a waiting period to assure that you reflect and deliberate over this request. This is one physician's flow chart of the steps that somebody has to go through to get a MAID prescription. But the upshot of that is it's designed to ensure that the request is voluntary, that it's informed, and that it's enduring. And it works. The evidence shows that there's a solid patient safety track record. It started in Oregon back in 1994. And that model has been followed, given the strong track record. Followed in Washington, Montana, Vermont, California, Colorado, Washington, D.C., Hawaii, New Jersey, and Maine. So as of today, people say that 1 in 5 Americans lives in a jurisdiction where MAID is a legal option. Right, and if you just add up the population of those 10 states and divide it by the U.S. population, that seems right. And it has very strong support, not only in those states, but generally in all the other states as well. So as of today, 10 jurisdictions in the United States where MAID is a legal option. And if you look at the years during which MAID has been a legal option in each of those states, and you add those up, you get to 70 years of combined experience with MAID across those 10 jurisdictions. And what do we know from looking at that 70 years of experience? And we know a fair bit because almost every state has a Department of Health that collects a fair amount of data on how MAID has been used in those states. And if you go through those state annual reports in each state, what you learn is generally only 0.5% of patients who die in those states have died from MAID, right? So 99% of deaths are completely unaffected by MAID. Who gets MAID? Most people, you have to be terminally ill. Almost everybody has cancer as their terminal illness. 90% of people who get MAID were on hospice. The median age is 74. Almost everybody who gets MAID is white, even in California and other diverse states. Generally, they're educated and affluent. Almost all of them were insured. Most of them graduated from college or went to college. And so the upshot is this, right? Most people already, and for decades, have been making a deliberate decision to hasten their death, right? Those dependent on dialysis, vents, clinically assisted nutrition hydration can and already do hasten their deaths, right? But some patients don't have any treatment to refuse or any treatment to turn off. And generally, people who are similarly situated should be treated the same. MAID simply gives those terminally ill, competent adults the same freedom as the others to control the timing and the manner of their death. And then there's one last thing, right? What's happening right now in early 2021? So far, all the bills have been modeled on Oregon, right? So they've been nearly identical. Washington is almost identical to Oregon, and Vermont is almost identical to Washington and Oregon, and so forth. But over the last few years, there's been a lot of investigation, and there's been a lot of argument and evidence to show that that model, that Oregon model, unduly restricts access to MAID, even in states where it's legal. And so there's been a big push now, and you see this especially in early 2021, to sort of break the mold, to break that Oregon model and to move away from it at least a little bit. And here are two of the key ways in which states are moving away from the Oregon model. One is that attending a consulting physician who confirms that you're terminally ill and confirms that you have capacity, that's always been a physician in the current 10 states. But we know that especially in rural areas, it's difficult. We have a shortage of physicians, and so that creates access problems. So the response has been what? Current states, some of the current states like Hawaii that already have MAID are now looking to extend that from physicians to nurse practitioners, or sometimes called advanced practice registered nurses. And then a lot of the new states, like New Mexico, that are seeking to legalize MAID for the first time, are also drafting their bills in this way to not limit the consulting and prescribing roles to physicians, but to other advanced practitioners. And it's worth noting that in almost every state, nurse practitioners already do the same sorts of things. So nurse practitioners can sign a POLST or MOLST form, for example, which is effectively a DNR order or withholding of life-sustaining treatment. And then the second thing that's happening right now, and I'll end with this, the second thing that's happening right now is the traditional Oregon model has had a 15-day waiting period. So the patient has to make 2 separate requests separated by at least 15 days. And in Hawaii, it's 20 days. And again, the idea is good. It's to assure that the patient's request is enduring and settled and well thought out. But again, the evidence has shown that it constitutes an undue burden because most patients can't wait that long. And there have been several studies, and there's additional evidence from Canada and Australia, that a majority of patients during the 15-day waiting period either lose capacity or die, right? So they can't last 15 days. They can't wait 15 days. So the response has been, last year, Oregon amended its statute to waive the 15-day waiting period, at least for the subset of patients that can't wait 15 days. And so again, you see that in a lot of the current bills in 2021 is to either allow a waiver of the waiting period if the patient's not going to last that long, or to just shrink the waiting period from 15 days down to sometimes 3 days. And then the genesis of this is I did this article in the Journal of Health and Life Sciences, which sort of describes the variations in U.S. laws currently and the variations that are going to come up. And I think that's going to constitute some of the questions Delano is going to ask me. So I'll stop there. Thanks. I'll stop sharing.
Well done, Thaddeus. I'm going to let that just sit for a minute. We have one question from Dean. Dean, I'm not sure if you want to ask it yourself or if I should read it to us. It's your call. So Dean asked, what is the difference between living will and post and moist form? I'm not familiar with.
Yeah, so that's a good question. So every adult in the United States should have an advance directive. Used to be called a living will, right? And that does two things. The most important thing is it's a vehicle for you to appoint an agent. If you lose capacity to make your own decisions, you've identified the person who will speak for you. And then secondly, the advance directive would allow you to list some specific treatment preferences, treatments you might want or not want. A PULST, and it goes by a lot of different acronyms, PULST, MOST, POST, MOST, is different. It's only for those patients expected to die within the next year. So it is only for seriously ill patients, not for all adults. And the reason for that is because the O in PULST it stands for order. So physicians authorize sustaining treatment. And that means that it's immediately actionable. If you have an advance directive and you show up at the hospital, they have to read your advance directive and then figure out what orders to write based on your advance directive. A PULST already is a set of orders. So that means EMS can follow it, nursing home can follow it, hospital can follow it. And so the idea is a PULST helps, at least for that population of patients, helps better assure that your wishes are followed than an advance directive all by itself, because there's that translation process with an advance directive, one, and then two, an advance directive is not immediately actionable. So for example, EMS, somebody shows up at your house, they can't follow an advance directive, which means you will be transported to the ED, and the ED probably doesn't have time to look at your advance directive, so then you'll probably go from the ED to the ICU and so forth. So a PULST for seriously ill patients is an important supplement. You wouldn't want to have a PULST instead of an advance directive, but for seriously ill patients, they should strongly consider having a PULST in addition to an advance directive.
And on the same note, Thaddeus, in terms of cases of dementia, how might an advance directive play out in this particular context?
So, well, two things. If you already have dementia to such an extent that you don't have decision-making capacity, then you can't have an advance directive, because advance directives are always completed by the patient herself. And if your dementia is too far advanced, then an advance directive is not going to be an option for you. But a PULST can still be an option for you, because a PULST can be completed in almost every state, by your legally authorized decision maker. So let's say you're already at stage 5 Alzheimer's, then your decision maker, hopefully based on discussions that you have with them and based on what they know about your preferences, could complete a post on your behalf. The other thing that we talked about a bit in some prior completed life initiative programs is that a lot of people are afraid of living in late stage dementia, so especially stage 6 or stage 7 Alzheimer's. MAID is definitely not an option for you in any jurisdiction except the Netherlands. But what you can do is complete in advance while you still have capacity. So you would have to have done this way earlier in your dementia diagnosis, but you can complete what's called a dementia directive, which might direct things such as comfort feeding only, or even stopping eating and drinking. So, and that would basically hasten your death, avoid living as long in late stage dementia if you didn't have such a directive.
Absolutely. And Thaddeus, if we can just dive a little bit into your presentation. In your article, you talk about the importance of verbs, and here in your presentation, you're highlighting some very important adjectives. And you mentioned voluntary, informed, and enduring. Could you take us a little bit further into that?
So this comes up a lot, right? Because we're opponents to legalizing medical aid in dying are very concerned that we're shortening the waiting periods, right? They've been 15 days. In Vermont, it's always been 17 days, and in Hawaii, it's 20 days. But now some of the bills are moving that down to 72 hours, and even that can be waived if the patient, is imminently dying. And so there's some concern that safeguard, which was designed to assure that the request is voluntary and enduring and settled, and well considered, is being taken away. But there's no evidence to show that the waiting period needs to be 15 days. So that's it's not an evidence-based safeguard. I mean, I think here's the thing. I think it is important to have a waiting period of some duration, and you should have to make 2 separate requests separated by some period of time. Even if you think of this is so common, right? Before you make any big decision, people say things like, hey, you should really sleep on that. Or if you think of the Michael Jackson song, Billie Jean, right? He says, just remember to always think twice, so it's a well-settled thing. Before you make any big decision, you should sleep on it and then think you still feel the same way in the morning. But I don't know that needs to be separated by 15 days, right? We have federal guidelines for sterilization, for example, which are only 72 hours. So we have other big consequential healthcare decisions that do have waiting periods, but they're not anywhere near as long as they are for MAID.
Excellent. Thank you so much, Thaddeus. David Hoffman raises a very intriguing couple of questions here, which we would appreciate your thoughts on. So David asks, how should the MOST form and a healthcare proxy form work together? Should the patient or surrogate discuss the MOST form before becoming within that 1 year window?
So that's unfortunately, this is not as well settled as it should be. So there's always one big question that keeps coming up is, let's say you lose capacity, can the surrogate complete a post form on your behalf that's inconsistent with either with your prior post form that you completed yourself or with your advance directive? And another way to phrase it is, does the post form trump the advance directive, or does the advance directive trump the post form? And unfortunately, the laws in some states leave the answer to those questions in a state of uncertainty. I believe that agents, whether your agent or your surrogate, does not have the authority to do something that you didn't permit them to do, right? So if your advance directive says, I never, ever want CPR, right? then they can't, then that would mean that they can't complete a pulse that would not be DNR. But unfortunately, the law, I think, doesn't always align with what I think the law should be. So I do, to answer Dave's question, it's absolutely important to talk to your agent that you're going to appoint to speak on your behalf when you lose capacity about your values and preferences. Those might be memorialized in the advance directive. So if they have to complete a subsequent pulse, right, as your condition changes, they know how to do that, and you told them how they should do that. So yes, absolutely. Ideally, that would happen. Unfortunately, we know that people don't talk with their families about what they would want, and the families are sort of just left to guess what they should do on the patient's behalf.
And it goes state by state in your research and observations.
So so advanced directives, pulsed, and MAID are all state level issues.
Mm-hmm.
I mean, financing, right? So we hear a lot about what Biden might do with 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 the Affordable Care Act and things like that. So the money often comes from DC and the feds, but in terms of the regulation of the actual delivery of healthcare, especially those three things, advanced directives, pulsed, and medical aid in dying, that's all governed by state law. And there's enormous variation from state to state.
We have an audience question from Kathy Kastner, which I would like to, we would appreciate your thoughts on, Thaddeus. Are the pulsed and MOST forms readily available at the time of decision, even if the patient isn't competent? Are these forms available at the time of decision if the patient isn't competent?
So, well, if the patient is competent, and we would use the word patient has capacity typically, but if the patient has capacity, the MOST forms are relevant, right? Because then if you want to know what you should do for the patient, just ask the patient. If she has capacity, just talk to her. So they're only really relevant when the patient lacks capacity. And so, but the question is, are they available at the time that they're needed? They're supposed to be. And so generally, the traditional model has been this. They've been sort of on a pink or lime green fluorescent colored form, which makes them very easy to find, right? So at your home, you can put it on your refrigerator, so EMS would know to look there. So generally, the advice on how they're used makes them findable. So they are typically available, in the moment. And then a number of states, especially Oregon and West Virginia, have registries. So everybody who has a pulse then effectively scans the pulse to the registry. And then as long as you know who the patient is, the clinician, whoever that is, ED, EMS, long-term care, they can query the registry and say, oh, does Delano have a pulse? Yes. And then it would download it. So registries, I think, are a big way to solve the problem that I think Kathy is flagging, which is having or completing a pulse is not the same thing as making sure the pulse is available at the time that it's needed. Same thing with advanced directives. We know that a lot of patients, we ask them, oh, do you have an advanced directive? Yes. Where is it? I don't know. So there's a difference between completing the advanced directive and the advanced directive actually being available to your clinicians at the time that it's needed.
Excellent. And on a similar vein, Thaddeus, Tim Quill chimes in. If I would want MAID, if I lose capacity in the future, right? If I lose capacity in the future, but I would want MAID, should I put this wish in my advanced directive and tell my proxy about this, even though it is not now currently an option in this circumstance?
Right. So it's not. So let me be clear. Right? It's absolutely not an option. There's no advance request for MAID. Right. The patient has to have capacity and request it herself contemporaneously to the clinician. Canada is considering allowing advance requests for MAID. The Netherlands already allows advance requests for MAID, and in the last few months has confirmed the legitimacy of advance requests for MAID, but definitely not available in the United States and probably won't be available in the United States for many years. But to Tim's question, sure, can't hurt to put stuff in your advance directive. Maybe after you lose capacity, it becomes available. But I would note two things. One is technically it's not MAID anymore, at least the way the word MAID is used in the United States, because MAID in the United States means that it's self-administered, meaning all the doctor does is write your prescription. You get the prescription and you take it yourself. If you now lost capacity, you're not knowingly ingesting that yourself. Probably somebody else is going to do it to you or for you, which means it's not MAID, it's euthanasia. So when we talk about advance requests for MAID, it's really an advance request for euthanasia. But sure, you could put that in there. I mean, you're the Shakespeare guy, but I remember, I think it's Macbeth, right? Where the guy says, look, I can call the spirits from the murky deep, right? And then the other guy says, well, so can I, or so can any man, but will they come when you call them, right? And so you could put it in advance directive. It doesn't mean anybody's going to follow it.
Yes, I guess unless your name is Horatio, you really won't have much luck. Dean asked a very compelling question as well, which in your October 2020 article, you talk about the states as being laboratories for MAID, and in our conversations leading up to this event, we've talked about federal and state law, and Dean has a very intriguing question on this very point. If the Patient Self-Determination Act is federal, then why is it that a state is able to take away this particular act on a person-by-person basis? Isn't the concept equal justice? And why is PSDA federal and you say and by state? I may have butchered that question a little bit, but I think there's documents there. I
think I get the gist of it. So the Patient Self-Determination Act is an act that was passed right after the Nancy Cruzan case in 1991. And it's important to note that all it does is it's a Medicare funding bill. So it's, in other words, if you take the Medicare dollars, then we're going to make you do all these things. If it's a condition of payment. And the PSDA simply says, when somebody arrives at your hospital or long-term care facility, you must make them aware of their rights under state law. So it's agnostic as to what those rights are, right? So and they vary from state to state. So the PSDA was very careful to be agnostic or deferential to what the states are doing. It's like, we know that the 56 jurisdictions in the United States are all doing different things. And we're not going to tell you what you can do, and we're not going to tell you what you cannot do. This is the federal government speaking. But whatever your rights are under state law, or whatever the rights are under state law, tell them what their rights are. So it's an information statute. It doesn't affect the content of those rights. It's just making you aware of what those rights are. So arguably, in Oregon, I mean, somebody might, just to give an example, the PSDA might, well, it gets tricky, but theoretically, the PSDA would say you have the right to medical aid in dying because that is one of your rights in Oregon, and in New York, they wouldn't tell you that because it's not a right in New York. But it's only about information providing. It's not about the content of the rights.
Excellent. Thank you so much, Thaddeus. And just as a follow-up to that question, if we think about, and this is from Susan, she writes, Thaddeus, I understand that you're talking about patients may self-administer, but that the patient must take the final overt act, and this is in quotes. Is there a distinction between a patient may self-administer and taking that final overt act? Is there a distinction? If an overt act is required, what happens where a patient is unable to physically participate due to a disability?
So that's a super important question. So Um, so California is the clearest on this. So California says that others can help the patient, right? So let's say you had to open up the 90 secobarbital tablets, those little, oval tablets, open each one and pour the powder, right? And then you pour it into your drink. So somebody can do that, mix it, they can get a cup, they can get a straw, but ultimately they have to hand it to you and then you have to drink it yourself, right? So that's what I mean is that they can do the prep work, but you have to drink it. And you're absolutely right that some patients cannot do that. And now there are some people have been thinking of, I guess, devices or contraptions, right? Where, let's say, if you have any physical muscular movement whatsoever, for example, an eye track, right? If you can use an iPad. People in locked-in syndrome have written entire books just by eye tracking because all they can move is one eye. So some people have devised devices, so then they can say, well, the patient caused the iPad to open a valve, which then release the medication into their body. But I think it's a problem which might be subject to legal action in the next few years, because either it violates the Equal Protection Clause because you have terminally ill people, they're all eligible except this class can self-administer and this class over here cannot self-administer. So you have two similarly situated populations and you're treating one of them differently. And worse, you're treating them differently, as you say, on the basis of their disability, which seems highly discriminatory. It may also violate the Americans with Disabilities Act to discriminate against someone on the basis of their disability. So you're right. There are people who I think have access problems because of the self-administration requirement. It's one of those things that just hasn't bubbled up to the surface in terms of public policy. But
yeah, absolutely. And I think this question from John Kelly segues nicely into what you just mentioned. Mr. Kelly is parsing the distinction between disease and disability, I suppose. As he writes, hi Thaddeus, since the motivating rationale for MAID is finding the disabling features of your disease intolerable, based on a diminished quality of life, your logic suggests that MAID should be extended to non-terminal disabled people with the same disabling features that might make life intolerable. Do you foresee this expansion towards disability from disease?
So John is a very articulate and vehement opponent of MAID, and he and I respect his pushing me to clarify. I do think that there'll be an expansion. There have been bills that have taken out the 6-month prognosis or extended it, right? So we've had bills to go from 6 to 12 months, and we've had bills that would take out that altogether, right? And it would still require an incurable and irreversible illness, but it wouldn't have that temporal component that you'd have to prognosticate that death would follow in 6 months. So I do think we're going to see that, right? As I said, the big focus legislatively is on the types of clinicians. We're going to expand the types of clinicians from physicians to nurse practitioners and sometimes to PAs. And we're going to change the waiting periods. That's the big focus right now. But if you just look over the last, in 2020, 2019, 2020, you do see a fair number of bills tinkering with the terminal illness requirement. It is worth noting when you step back and look at this from a worldwide perspective, the US is unique in being that demanding, right? So any other jurisdiction in the world that has MAID as a legal option doesn't have a strict 6-month prognosis like that. So the U.S. is kind of unique in the world in being that limiting.
Excellent. We'll have a couple of questions from an audience member. One is, and you mentioned this in your October 2020 paper, but I guess to kind of bunch this constellation of questions. So David Hoffman raises the question about medical tourism, but also we also have other questions dealing with the idea of, is it common for opposing doctors to state that they are unable to attest to the patient's ability? And yeah, I guess that's the question. Is it common for opposing doctors to state that they are unable to attest to the patient's ability? And I guess we kind of fine tune that question a little bit. What happens if a clinician or a physician says, "I don't want to do it. I don't want to participate"?
So every law in the every state in the United States, 10 jurisdictions in the United States are very, very clear that nobody has to participate in MAID if you don't want to participate in MAID. So the conscience-based objection clauses, is what we would call them, the right to opt out is protected. It's very clearly protected. So no individual clinician has to participate in MAID if she doesn't want to, and no facility at institutional level has to participate in MAID if it doesn't want to. So everybody can opt out. The only limit on that is that you do have to transfer the patient's medical record. So if the patient is currently being treated by, let's just say, a Catholic doctor at a Catholic facility, and they don't want to participate, and then the patient finds another physician who is willing to participate in MAID, the previous treating clinician must transfer the patient's medical records to the new physician. Now, they might consider that to be to make them complicit because they are facilitating the patient's access to MAID. But the state basically had to draw the line somewhere, right? And had to balance the patient's right to access what is now a legal option in this state versus any clinician's right to not participate in what they deem to be something immoral. And that's basically where the line is drawn. You don't have to make a referral. You don't have to make a diagnosis. You don't have to write a prescription. But we had to require at least that much. You do have to transfer the patient's records because otherwise the patient would have to start, all over from scratch, and it would be anyway. So that's how we'd strike the balance.
Are patients allowed to travel across state lines to have MAID?
So yes, they are. Every state requires, as one of the conditions of eligibility, terminal illness, 6-month prognosis. One of the other conditions of eligibility is that you're a resident of that state. But when you look at what the requirements are for being a resident of any of these states, they're very, very easy to satisfy. So, for example, one is that you own or lease property in that state. So you or I don't know, right? We could do this right now. We could find some apartment on Craigslist in California, send a check through PayPal, and now we lease property in California. And at least as far as the California End of Life Options Act is concerned, we are residents of California. So the legal obstacle to medical tourism is weak. The big problem is not the legal requirement of being a resident. The real burden is that you're a terminally ill patient and you have to move to this other state, and you have to find both a prescribing and a consulting physician who are willing to participate in the process for you. So it's the practical problem, not the legal problem. But Brittany Menard, I think, is probably the most famous example, right? She was a California resident years ago before California legalized medical aid in dying, and then famously, because this got so much press coverage, moved with her husband to Oregon and accessed medical aid in dying in Oregon. But that's just the most famous and most visible example. But there are many other examples of patients moving from state A to state B. So that can happen, and it does happen.
Excellent. Thank you, Thaddeus. And just a quick follow-up question. This is a very direct question. Why not use the term assisted suicide for MAID?
Yeah, that's a good question. One reason is this. From a strictly legal standpoint, the statutes specifically say that MAID is not suicide. Now, you might disagree with that, and maybe the legislature should not have done that, but officially, it's not suicide, and they did that for a number of different reasons. One is that they didn't want the fact that you used MAID to affect your life insurance and other consequences that might have followed had it been actually characterized as a suicide. But that's my first response, is that every single statute specifically says it's not suicide. Your duly elected representatives, if you believe in the democratic process, we decided that it's not suicide. And then secondly, I think there's actually a rationale for that, other than the purely instrumental one I just mentioned, which is suicides are traditionally examples where somebody's acting often without capacity, they're not terminally ill, and I think it's very different than what we're talking about here, which is somebody who's already dying. All they're doing is controlling the precise timing and manner of their death, and it's a decision that's made with counseling and supervision by licensed clinicians. So I think it's so different than what's traditionally thought of as suicide that it seems inappropriate to characterize it as a suicide. And in fact, the American Association of Suicidology and others have even said it's so different that it shouldn't be called, we need a separate term because it's such a different sort of thing.
Excellent. Peggy Batten has a rather intriguing question. Our country, the U.S. is unique in requiring a 6-month terminal diagnosis for MAID, but other regions often require unbearable or intolerable suffering. Should we be doing that instead?
So it's worth noting that what's unbearable is completely subjective, right? So it's normally, if the patient says it's unbearable, it's unbearable. I think that that's something to consider. I mean, to be fair, right? Australia is the closest to us because they do have a 6-month limit, but they extend it to 12 months for some sorts of diagnoses. So they're nearly as restrictive as us, but they go to 12 months in some situations. But all the other jurisdictions are way more accessible and don't have that temporal prognostic requirement. I think it is worth looking to Canada. So Canada does what Peggy just said, which is unbearable suffering, and and they have now years of experience in Canada. It's worth noting that for the last few years, they've also had not just unbearable suffering, but also the death had to be reasonably foreseeable, which is pretty flexible when you compare it to a 6-month prognosis. But a court struck down the reasonable foreseeable requirement. And so they had a weak or a soft or flexible temporal requirement than we did. But now even that is going away when later this month, the Parliament is going to amend the assisted suicide legislation in Canada. But the bottom line, Peggy, is I think changing that eligibility requirement hasn't proven the sky is not falling, right? I think that this sort of public policy making should be done in an evidence-based manner. And we have a lot of evidence, right? Canada has tracked this very, very carefully. So you could look, well, they have a different eligibility condition. Has it turned out terribly? No. So I think you can look to evidence. and you don't just have to guess, oh, should we take out the 6 month? Would that be terrible? Other people already did it and have done it for years, and it's worked fine.
Fascinating. Thaddeus, a question from Christine Salzberg. What is a viable alternative to MAID for someone who is quadriplegic, can guide a wheelchair with one finger, can write a book with voice, and can swallow, but cannot hold a cup?
Well, so first of all, I think that if you, like I said, I think there are clinicians who have devised devices such that if she were in a state, or that person were in a state where MAID was a legal option, that you could find a way that the person could be the final actor of self-administration. The often what you, and this is common in the press, right, is you see people who wanted MAID who couldn't access MAID either because it wasn't a legal option, or because they couldn't find a willing clinician, or because they can't self-ingest. And then typically the backup option is VSED. This is written about, all the time in books and films. That's often the backup option, right? Because you don't need to ingest anything. It's the opposite, right? You're not ingesting anything. Now you still need clinician support to alleviate the symptoms from dehydration, but I think VSED is often seen as the backup option to medical aid in dying.
Thank you, Thaddeus, for that. I guess one thing that comes up when we think about end of life issues is the idea of dignity, and having choice and voice, things of this sort. Would you mind commenting on Switzerland's Dignitas program?
So Switzerland is interesting. So a couple things about Switzerland. One is almost every other jurisdiction in the world that allows medical aid in dying also allows euthanasia, meaning they allow either self-administration or clinician administration, right? So that's true in Canada. That's true in all the European countries except Switzerland, Australia, and New Zealand. So the United States is sort of unique in the sense that it only allows self-administration. It prohibits clinician administration. But Switzerland that's the one place where we in Switzerland are the same. We're the only two that do that. But the one difference between us and Switzerland is the clinics, the two big clinics, Pegasus and Dignitas Clinic, that have a lot of medical tourism, so people from other countries come to Switzerland, is that they typically do it through IV self-administration. So it's still self-administration, and they're very careful to say the patient has to push the button, but they're typically not drinking. It's an IV, and that's interesting because in the United States, we also require self-administration, but none of the self-administration in the United States is with an IV. So that's something to consider because IV administration is actually safer. What I mean by safer is there's a fair number of patients who ingest by drinking, but it doesn't work, meaning they wake back up, they have seizures, they regurgitate the medication. And so the whole point was you had a comfortable and peaceful and relatively quick death, but a fair number of patients do not. You don't have the side effect. You don't have those side effects when you have IV administration. So I think that's something we should look to Switzerland because we have similar laws, but we have very different practices.
Absolutely, and in the case of New York, for example, where it is difficult to have a living will honored, or even to even have, in the case where someone lives in New York, has a living will, but does not have an appointed healthcare agent. Why would it not be reasonable for that person who has firm wishes to complete a post or a MOST form, since it covers so many, if not most, of the items in living wills? Why is it difficult to have those access to those forms in a state like New York, where living wills aren't easily honored?
Well, I don't know that. I mean, there are some laws. I mean, we did a story a few days ago in the New York Times about some New York cases where the family is suing, I think Montefiore and a few other hospitals for not honoring an advance directive. But I think at least in one of those cases, the lawsuit is also concerning that they didn't honor a MOST either. So generally, the whole point of doing this is we promise patients, we go to patients and we say, and there's a lot of people that do this, right? Advanced care planning facilitators, there's lots of nonprofit organizations, the state government, the Department of Aging. A lot of people are saying, hey, you should do an advance directive. Tell us what you want, tell us what you don't want. That helps assure that you get value concordant care. And then the patient does everything they're supposed to, and they complete an advance directive, they complete a pulse, and they still get treatment that is specifically refused, right? So it's sort of a real breach of a promise that was made. I do think, though, maybe if I get into just the question, if you are seriously ill and your doctor would not be surprised if you died within the next year, then supplementing your advance directive, or I think you said this, you can have a pulse, you don't need to have an advance directive, or just having a pulse and there's a lot of evidence on this, so there have been a lot of studies, a pulse helps assure value concordant care better than an advance directive. So you definitely, if you're seriously ill, should supplement your advance directive with a pulse. It maximizes the chances you're going to get what you want and not get what you don't want. And yes, you can definitely have a pulse to not have an advance directive. It's generally not recommended, but it's definitely perfectly legal and possible.
Yeah, and just as a point of clarification, David Hoffman points out that living wills advance directives are indeed valid in New York. So we just want to make sure that we're putting out the best information.
Right. Yeah. They're valid. They're valid everywhere. So they're valid everywhere. The question is, right, it's all so there's this legal status. They're absolutely legal documents. There's statutes behind them. There's regulations behind them. But then, as we talked about, there's all these practical problems like Kathy Kastner raised, which is, are we going to find them? Are we going to understand them? Are we going to do what they say? Are we going to misread them or misinterpret them? So there's a lot of problems at the stage of implementation.
Absolutely. I guess, and part of the problems, as you say, with implementation is that states still have a say in this matter.
Well, I think the implementation is, sadly, there's a lot of problems, right? I mean, one is people don't do them. I mean, that's the biggest problem. Like, most people don't have an advance directive or pulse that maybe should. But another one is they don't write them very well, so it's not very clear. Or they appoint an agent, but they really should appoint the backup agent or two backup agents. We had a case this week at a hospital that I work with. Their agent had COVID, right? So they had appointed an agent in the advance directive, but the agent wasn't available. So useless, because so it would have been great if they had appointed a backup agent, an alternate agent, because their primary agent wasn't available. But then what's actually maybe mentioning is there's a guy at UPMC, University of Pittsburgh Medical Center, Fred Morarchi, who's done 10 or 15 studies on advance directives and pulse. And unfortunately, what his research shows, and it's published in the Journal of Patient Safety, is that clinicians misread it. It's scary. It's scary research, because what he shows is, for example, the mere fact that you have an advance directive, they think, oh, therefore Delano has an advance directive, he must be DNR, right? In other words, they infer one thing from the other. But of course, you can write an advanced directive however you want. The mere fact that you have one doesn't mean that you're DNR. But unfortunately, a lot of clinicians make that inference wrongly. And it has a lot of similar research like that. So it's not a legal problem. It's a training problem, really, at the clinic level, which is, this patient did everything right. She completed advanced directive, she completed a pulse, but you misread it. You didn't interpret it and figure out what actions to take or what actions not to take based on the patient's documents. So that's why I called it an implementation problem. I think the law is fine. It's that we need to make sure that they actually get correctly interpreted and followed.
Yeah, and I definitely think too that particularly you're kind of I'm thinking back to your flow chart that you had in your slide deck, which seems amazingly complex, and in terms of interpretations, it can be even more heart-rending, to kind of really say the least.
Well, that's why. For example, the classic example is people writing an advanced directive. I don't want any heroic measures or extraordinary measures. What does that mean, right? It's a very, very unclear term when you try to apply that to like the specific situation, right? The patient needs pressors, or they need dialysis, or they need. Is that so? It's unclear what that means in the patient's current situation. So. That's why almost always clinicians don't want to just read an advanced directive and figure out what to do. They want to talk to somebody. So the advanced directive really is not for clinicians, it's for your surrogate. And then it would give them some guidance and give them some direction and give them some comfort that whatever they're asking for you is what you would have wanted. I do think that advanced directives are primarily for the agent, not directly for the clinician, but a pulse is directly for the clinician because, like I said, it's an implementable order set. So that might be one way to distinguish the two, is the audience for a pulse is a clinician and the audience for an advanced directive is your healthcare agent. Absolutely.
Just a few more questions on Thaddeus. Your lunch hour is definitely a rigorous examination, and I love the questions we are receiving. One other question is, in your paper from October 2020, you point out the uptick in medical aid and dying across states. What have in your research? What are some dominant trends, or can you put your finger on a few trends that has witnessed this increase in MAID in the U.S.?
Well, so when I say increase, I think what you're referring to is the fact that it's been expanding across the country, right? So we used to only have Oregon, and then we went from Oregon to Washington and so forth. But you're right. But in the past few years, we've doubled. Right? We've doubled the number of states that it was before that. And many people expect this year to be New Mexico, Massachusetts, Maryland. We could get 2, 3, or 4 states in a single year in 2021. Why has that been happening? I think it's evidence-based. It really is that the track record from the states that already had it is solid, right? We don't hear reports of people being involuntarily, somebody shoving the medication down somebody's throat. So like I said, the patient safety record is solid, and there are people, right, who are actively looking for bad evidence, and they just haven't been able to find it. So each state. And you could go into their website, right? Each state at the hearing generally looks at the record from the prior state. So I think as we build a better and bigger evidence set, the case for legalizing medical and dying becomes stronger and stronger every year. And then combined with the massive amount of public support, we have 75% of the public and even a majority of licensed physicians in each state who are in support of it. Just from a purely political perspective, you have majority support for legalizing this option.
And I guess on that same point, Thaddeus, in terms of patients having a voice, Faith Somerville asks, what, if any, do you see as the most hopeful forms of advocacy to get more states in the U.S. to bring bills to the floor? And a follow-up question to that is, are there steps the average citizen might take to make MAID a reality in their state?
Yeah, that's a good question. I'll be humble and say I'm a law professor, so I guess I focus on the content of the law. When you move from where I am as an academic over into advocacy, I defer to the experts. And when I say the experts, in my mind, there are two. One is the Death with Dignity National Center, and the other is Compassionate Choices. So I think that if you want to help legalize MAID in your jurisdiction, I would contact one or both of those organizations and say, hey, how can I help? Because they hire professional lobbyists. They know all that secret information about who chairs the Judiciary Committee, who chairs the Health and Human Services Committee in the Senate and in the House. And that's the kind of level of information you need to really know how to get a bill. Who's the right sponsor? Do we start in the Senate or do we start in the House? That kind of tactical information, that's what they're the experts on. And I think that they would love people's help. I mean, either they would love you to check, of course, but I think if you had a story, you had a family member that had a bad death, maybe they would say, hey, we'd love to have your testimony at this committee hearing and things like that. So I think I would definitely contact one of those two organizations. And some states also have a state level organization. So Illinois has something called the Illinois End of Life Options Group, and many other states have a similar organization as well. But I think that those are the guys that really are, I think, repeat players, meaning they were there in Oregon and they were there in Maine, they were there in New Jersey. So I think they have the most experience in professional advocacy.
Ashley Sweet asked you a question of you, Thaddeus, that kind of wants to know why. She writes, Ashley Sweet writes, Dr. Pope, why did you choose to focus your career on end-of-life decision-making? And a follow-up question is, what do you think is currently the greatest legal challenge for patients seeking MAID in the U.S.?
So that's a different kind of question. So
yeah. One is getting behind the JD and PhD, and the other is asking you to think in terms of trends.
So I wrote my this is 30 years ago. I wrote my doctoral dissertation in philosophy at Georgetown on paternalism, right? And paternalism is this idea that one person interferes with the liberty of another person because, you think you know what's better for them than they know for themselves. So I'm not going to let Delano do something. I'm going to make Delano do something because I think I know what's best for Delano better than what Delano knows what's best for Delano. And that's profoundly insulting, right? We generally reject that kind of thought that everybody should be their own captain of their own ship. And the reason I got into this is because there's two big places where paternalism, to try to translate my doctoral dissertation into practice, one was public health, right? Which was motorcycle helmets, seatbelt laws, and that sort of stuff. That's one place where paternalism got a lot of discussion. But that's not really pure paternalism because there's always negative externalities, right? If you don't, generally there's going to be third parties that are going to be affected. But in healthcare decision making, the paternalism is pretty pure. Nobody else is typically harmed by your choices. And so that's really how I got into it, was taking this theoretical work and thinking, how is this practically relevant? And there's a lot of paternalism in healthcare still. We thought we got rid of that in the 70s with the patient rights and women's rights and those other movements. We didn't. And frankly, I think the biggest obstacle to MAID is something that's not even unique to end-of-life decision-making. It's a problem in all of healthcare. which is a problem of good informed consent. Meaning there are patients who are close to death, either because of cardiac issues or cancer issues, and their own doctors never told them, right? So it's hard to be in power and to take control of your end of life journey if you don't even know that you're at the end of life. So I think that just in terms of how many people are affected, I think that that's the biggest intrusion onto individual liberty at the end of life, is the fact that we don't tell hundreds and hundreds of thousands of people that they in fact are at the end of life.
Truly compelling. And one point you also raised, Thaddeus, in your October 2020 paper, is the idea of safety. And what does safety mean in the context of MAID?
So I think it means, the first thing it means definitely is that we have no false positives, meaning everybody who gets MAID is somebody who truly wanted MAID, right? They made a voluntary, free, and informed decision for MAID, right? And we don't have, so we're not giving prescriptions to people who didn't really understand what it was, or to people who really didn't even want it. So I think that's the first part of safety. And then the second part is what we talked about with the self-ingestion requirement, is that is it effective? Meaning, if you look at the Oregon data, you have a 4, 5, 6% rate of complications with self-ingested MAID, and that could be reduced basically down to zero if you either had self-administered IV MAID, which is probably at least politically possible, or you just allowed clinician administered MAID, as we do in Canada and New Zealand now, and even in Australia. So that's what I mean. That's the second part of safety. So one is to make sure that they really wanted it. The second is, once you get it, to make sure that it's a quick, peaceful, and comfortable death. And I think we don't have a problem. There's no evidence that we have a problem in that first aspect of safety, that we have any unwanted MAID. But I think there is a little bit of a patient safety problem on that second part, which is it quick, peaceful, and comfortable because of that complication rate?
Absolutely. And you just kind of, I think you and David were in sync there, David Hoffman, because in the chat he just put that what everyone wants from end of life care is an intervention that is safe, certain, and painless.
It's worth noting, right, that's why people want a medically supervised death, right? I mean, people can hoard pills, and they could do other sorts of do-it-yourself things, but they're really, really afraid that it's not going to be completely effective, and they're going to end up in an even worse state. I mean, they already are in a bad state. That's why they're thinking about ending their life, but they definitely don't want to end up even worse than they already are, right? So there's a big fear of that. So I absolutely agree with David, right? There's the whole point of trying to, of seeking to hasten death through medically supervised means is because the non-medically supervised means, buying Nembutal over the internet, people are really afraid that whatever shows up in the mail is it really going to be Nembutal, or is it really going to be at the sufficient concentration that's necessary? And so, because you're acting in the black market, so you're not really sure what you get. So I think that's a big concern.
Yeah, absolutely. In terms of a completed life, Thaddeus, why does MAID matter?
I think it matters because there are some patients. I think it's worth noting, right? Most hospice addresses the existential and physical suffering of most dying patients, right? So most people aren't looking for ways to actively hasten their death, but some are. And right now, like I said, people who are dependent upon forms of life-sustaining treatment can turn those off. Anybody can make a decision to VSED, but VSED is, for most, is not as preferable of an option as MAID, because it takes 10 days 2 weeks, 20 days. It requires a lot of willpower. So it's not an easy end of life option. It can be peaceful and comfortable, but it also requires a little bit of effort. And so MAID is generally very, very quick and easy, at least once you have medication in hand, because once you take that medication, you will fall asleep really quickly, right? You might not die for a few hours, but you're going to be unconscious fast, right? So it's thought to be way more comfortable, way more peaceful than VSED, which is, I guess, the primary alternative. So again, the numbers are small, right? We're talking in the whole state of New York, a few hundred people per year. In any state, a few hundred people per year. So it's not a big population, but for those people, it really matters, right? They really didn't have that. They thought of all their other options. They were informed and counseled on all their other options, and they thought this is the best option for me. And so for that population, it provides a lot of comfort and peace of mind.
Absolutely. What has surprised you most in your work, doctor, in terms of thinking about end of life care, patient choices?
A lot of stuff. That's a great question. What's amazing is you think, oh, I've read 20 books on this topic, and then you go to an ethics committee meeting, the next afternoon, and you see something like, wow. So I think maybe the biggest thing then is is the gap between theory and practice, right? So in bioethics, we study all this stuff about patient autonomy. We can read 20 appellate cases. We can read the guidelines from the National Hospice and Palliative Care Organization and whatever, right? You could read all this stuff and think, okay, that's the way it works. That's the way it's supposed to work. These are the rules. These are the guidelines. And then you go to your local hospital and you see, wow, that's not exactly the way it works. So it's a gap between principle and practice. And we definitely should try to bridge that gap. But I think that's the thing. And it doesn't cease to surprise me, right? Because I sit here, I'm an academic in my quote ivory tower, right? And I think, oh, this is the way the world works. And maybe it's the way the world's supposed to work, but it sure the heck doesn't. I think that's the thing. I think that continually surprises me is how big that gap is.
Yeah, absolutely. And you really are getting into the human practice of not only law but also of medicine. And our friend Nicole writes, I heard on another webinar that doctors don't have to follow advanced directives. Is that true? And if so, what should your proxy do if a doctor refuses to follow your advanced directive?
So I don't agree with that. So we did this story, I think it was just a few days ago in the New York Times, where we reported on several recent lawsuits, successful lawsuits, right? One was the recovery was $1 million, two where the recovery was $1 million, and one where the recovery was $400,000, right? So the whole point of those lawsuits was to send the message that you do have a duty to follow advanced directives, because if you don't, we're going to sue you and we're going to win. It's also worth noting, if you go into the database of the Department of Health for any state and you look at the fines, right, they'll give you the reports, that there's a fair number of significant fines, right? I can think of just a few from the past few weeks where somebody didn't follow an advanced directive and they were slapped with $20,000 fines each for each incidence of not following a resident in a long-term care facility for not following a resident's advanced directive. So maybe there's some jurisdiction where the law is a little bit different, but generally across the United States, there is a legal duty to follow an advanced directive, and it's an enforceable legal duty both through administrative action, meaning whatever state agency regulates that type of healthcare facility or healthcare professional can discipline them, meaning a physician can be disciplined, a facility can be disciplined. And at the same time, you do see, and this was the point of that article in the New York Times, was civil people are willing to bring civil actions for money damages as well, and increasingly those actions have been successful.
Yeah, absolutely. And doctor, just on that same point, it seems to me as if Vermont is putting some safeguards in place in terms of ensuring that physicians don't, quote unquote, get in the way. Is that fair to say in terms of patients' directives, advanced directives?
I'm not sure I get it.
If a physician has an objection to MAID, in Vermont in particular, there seems to be safeguards.
About MAID. So in Vermont, Vermont is a little bit different because Vermont passed a completely separate statute called, I think it's called the Patient Right to Know Act. So this goes to this big problem I flagged when you asked me what the biggest thing I'm surprised by was. So given that many patients aren't aware of their end-of-life prognosis or their end-of-life choices, Vermont passed a completely separate statute. This was before the MAID law. It's called the Right to Know at the End of Life law, which means you have to tell your patients about all their end-of-life options. So that's what that statute said. New York, by the way, has a very similar two sets of statutes. I think one's called the Palliative Care Information Act, and one's called the I forget what the other one's called. But what happened was there was a litigation about how does that law intersect with the conscience-based objection rights under the MAID law, and the way it ultimately got resolved by the federal court in Vermont was, in Vermont, unlike the other states, you not only have to transfer the records if you object, but you also have to make the patient aware of their MAID, of what MAID is, and that MAID is an option. Now, you don't have to talk about it with the patient yourself, but if you are unwilling to do that because of your conscience-based objection, then you have to send the patient somewhere where she can learn about her MAID option in Vermont. So no other state requires that level of, you might call it referral, right, a duty to refer. Only Vermont requires the duty to refer. The other states, you can say, I'll talk about it with you, and I'm not going to tell you where you can learn more about it. But in Vermont, you do have to make sure you have to help the patient learn about this option.
Absolutely. Does insurance or Medicare cover MAID-related services?
Well, Medicare definitely does not, because after Oregon enacted its law in the mid-90s, Congress, in DC, federal Congress, enacted, I think it's called the Assisted Suicide Funding Restriction Act, ASFRA, and said no federal money, no federal dollars can be spent on assisted suicide. So that would include Medicare. So definitely, and like I told you, the median age for people who use medical aid dying is 74. So for those people, their primary form of healthcare insurance is Medicare, but Medicare won't pay for it. So, but other forms of insurance do. So if you have a Medigap policy, or if your spouse is still working and you have Blue Cross or something, right? Other private insurance often does pay for it, but Medicare or any other federal payer, whether it's TRICARE, veterans, and any other federal program is not going to pay for it. Cannot pay for it.
Understood. And Karen raises a great question as well. Really going back to your point of enhancing safety. She writes, as MAID expands, do you envision an emerging clinical specialty in aid in dying with residency, fellowship, board certification, etc.?
That's a great question. I think it's interesting. I mean, there is a new organization. It's only 1 year old, like today, basically. It started last February. It's called ACA MAID, American Clinicians Academy on Medical Aid in Dying. And what they're focused on is how to deliver MAID in a safe and effective manner. So it's not on legalizing MAID as an option. Their focus is, okay, given that it's already legal in California, how do we deliver it in a professional and appropriate manner? So I think that's a great question for ACA MAID. Just thinking out loud, I think one challenge is the numbers are still so low, right? Even after over 20 some years in Oregon, it's the numbers of people who are using MAID are very, very small. So what I'm not sure is can you specialize? How many people can specialize, given the entire tiny population of potential users? But I do think what I think ACA MAID is doing, though, is I think they are trying to professionalize it. Because let's say you're in New Jersey. New Jersey never had MAID before last year, right? It's how do I do it? What drugs do I use? What's the best way to counsel? What if the patient asks me this, right? And so I do think that the whole point of ACA MAID is to develop best practices, share and disseminate best practices. So it is what you might call a professional association, professional society, the same way that nephrologists will have the Renal Association and oncologists will have the, ASCO, the American Society of Clinical Oncology. So I think at some point it's sort of almost gelling as a profession or as a specialty, in the sense that it has an organization and it has and maybe they will move to some kind of test, where you have to pass the test to become credentialed in the same way that people have to pass boards to get a board certification.
Yeah, absolutely. And doctor, in your paper, you have that very great sentence about innovation and nonconformity are positive developments. And I think to your point, this is something that's currently in progress and will definitely take the shape based upon what the states want for moving forward with this matter. But just a couple other quick questions, and well, one is from Pat Fisher. Is there a way to compare MAID statistics by county in California?
That's a great question. I don't know the answer to that. I suppose there probably is, because there's a lot of paperwork that the prescribing physician has to submit. And I assume that the Department of Health, that captures the zip code of the prescribing physician. So I think that the answer is yes, we could do it. The DOH isn't reporting that because they're only reporting what the statute told them to report. But I think we have the data. I don't know if you can get like a Freedom of Information Act sort of, if you're a researcher, some kind of social science researcher, you can go and get that and then report it. Because a few days ago, the Netherlands reported massive variation. So they report a 4% use of MAID in the Netherlands, but that 4% is the average for the whole Netherlands. And in Amsterdam, it's like 13%. So it varies quite a bit from place to place within the Netherlands. And I do think that that would be worth exploring, because we know that with respect to other stuff, everything from tonsillectomies to pick your healthcare service, that there's massive geographical variations for no reason whatsoever. At least no patient reason whatsoever, right? So that it's supplier-induced variations. And if there are big supplier-induced, meaning physician-induced variations, I think we would want to know about that, because you would then want to know, why is there this variation? Why are people in this one county in California getting MAID at a much higher rate than people in other counties? So it's a great question. I think it should be investigated, and I think we do have the data that that somebody could generate the map, right? And it would be colored red for the high usage, and be colored some kind of way. We should do that. Great question.
Absolutely. Doctor, we're at the appointed time. However, just one tiny question, and then we will move on. In places where MAID is legal, what constitutes an undue burden?
So I think an undue burden, and this I don't have time to unpack it, but yeah, that's the term that we use in abortion jurisprudence, meaning abortion is a constitutionally protected right, since 1973, and when places put burdens like a waiting period and things like that, that's the term that we use to measure, it's okay to impose a burden on a constitutional right, but it has to be to serve a compelling state interest, right? And if there's no evidence to show that the burden advances any public health or public safety objective, then it's deemed to be an undue burden, because then you're restricting somebody's access to a constitutionally protected thing for no reason whatsoever. So I think you can transplant the undue burden analysis from the abortion jurisprudence to here to say, okay, we're restricting somebody's right to get made. Why, right? And I think when there's no good reason, then it means it's an undue burden. So the quick example would be Hawaii, which went stronger than everybody else. So everybody had a 15-day waiting period. Hawaii said, hey, we're going to have a 20-day waiting period. I think it was just for the political point of being able to say, hey, we took all the existing safeguards and made them stronger. It sounds good. Why not, right? Why not make them, if 15 is good, 20 is better. But there's no evidence to show it is better. So basically, you've made it harder to access MAID in Hawaii by making the waiting period even longer. So you're achieving no public safety or public health objective, but you are restricting access to MAID. So that's what I would say is undue burden, is when you're restricting access and you say, okay, why? What objective are you achieving by adding in that extra safeguard? And if there's no answer, then I think it's definitely it's not just a burden, it's an undue burden.
Thank you so much, Dr. Pope, and thank you so much for spending lunch with us.
Thank you for having me.
Thank you both. Delano, you've been an incredible moderator today. It's been a joy to sit here during lunch with you. And Thaddeus, thank you so much for bringing your presence and your expertise. It's been a fascinating lunch hour. I've learned a lot. I'm brimming with questions, but I will hold off on asking them because we are out of time. Thank you all so much to the audience for your incredible questions as well. It's been a lively discussion. So thank you again. The recording will be posted. You'll receive an email with the link, as well as some follow-up resources, a link to Thaddeus Pope's article on the current status of medical aid in dying in the United States. It's a great read. I highly recommend, and he goes into more detail about what he's touched on here today, as well as the article that was mentioned in the chat by Dr. Quill on the do everything approach. So highly recommend. Those resources will be sent out to you shortly. And please join us again in the near future for more completed life events. We love to have you here. And please stay tuned. Please check out our website, completedlife.org. And we look forward to seeing you next time. Thanks so much.